Mrs. Chairperson. So Assalamualaikum and a very good morning to everybody. So let me share the screen first. Okay, first and foremost, I would like to thank the organizing committee for inviting me to share a little bit of my knowledge with regards to this topic. I would rather prefer to carry on this session informally, boleh? We do it informal so that we don't have any barrier. Any question? If any of the audience got any question, can boleh tanya soalan lah afterwards. Okay, so my presentation today will be divided into two because you are giving me two topics to cover. The first one is the principle of antibiotic therapy in surgery, and later part of the discussion, we will talk a little bit with regards to role of surgeons during COVID-19 pandemic. Okay, so we start. Okay, the principle. First, you got to understand the basic principle of anti-infective therapy. It is crucial because it needs to be taken care of because to ensure an optimal outcome for the treatment of the patient, as well as to lower the incidence of complication of antibiotic therapy. And at the same time, another important factor in initiating antibiotic therapy is that you have to have at the back of your mind the issue of emergence and transmission of antimicrobial resistance. So I would like to first highlight this issue about antimicrobial resistance. It is largely contribute due to the overuse and misuse, irrational use, inappropriate use, and suboptimal antibiotic therapy. All of these factors contributes to the emergence of antimicrobial resistance. And logically, in the conditions where you don't think that bacteria is the causative factor of the patient condition, you should not give antibiotic to the patient. And only to use it when it is indicated by choosing first the narrowest spectrum possible, which most likely able to achieve clinical cure for the patient, and treatment for the shortest effective length of time. Okay, I've been talking about selective pressure. So once you introduce a form of antibiotic treatment to a patient, but in particular antibiotic with a wide spectrum coverage, as you all know, in our body, there's lots of bacteria. Either they are contaminants or colonizer. Once you expose them to this kind of antibiotic, those which are susceptible will die off. But however, among this population of bacteria, there are antibiotic resistant mutant. Once they are exposed to this kind of antibiotic, this mutant strain will be selected to replicate further on, thus leading to emergence of AMR. Okay, I think all of you agree with me that antibiotic is a wonder drug. Ever since penicillin is discovered in 1940, I think medical field recognize antibiotic as the wonder drug, since it is can easily be produced, it is relatively cheap, and you can easily have an easy access to antibiotic. You can also get it over the counter, and it has a very simple format of prescription. You can give it orally, and generally penicillin is quite effective and very much well tolerated by the patient. So in view of this factor, we tend to overuse or misuse this easily available medication. All right, so this is a study conducted in a health center basically in US. It has found out that appropriately roughly around 30% of the antibiotics that is being prescribed inside that healthcare setting is actually unnecessary or inappropriate. Even we have a local data where it shows that up to 50% that antibiotic that is being prescribed in a particular hospital that are deemed inappropriate or unnecessary. So we don't want that. And what makes things complicated is that bacteria is a very clever organism. They are capable to exhibit resistance not only to single antibiotic but to multiple antibiotic. And in particular, this kind of bacteria, the multi-drug resistant bacteria, can be found in a hospital setting where lots of antibiotics being used. And at the same time, a hospital-acquired infection is significantly likely to be caused by this multi-drug resistant organism. And the direct effect is that it will prolong the hospital stay of the patient. It will lead to increase in morbidity and mortality and increase the cost in managing the patient. And you also, in the end, will scratch your head what kind of antibiotic that you want to use to treat the patient. Because you treat with this kind of antibiotic, the result can be as resistant. End up, you don't have any other option. And we have seen for the last few decades, there's no new class of antibiotics are being discovered. The pipeline has come to its end. Okay, this is the data produced by US FDA with regards to the production and authorization of usage of new classes of antibiotic. It is diminishing. All right. So this is the antibiotic pipeline. Ever since being discovered since 1930 to 1940 and started from 1990 onwards, there are no new class being authorized for use as for treatment for patient. And by 2050, WHO have estimated that the annual death from antimicrobial resistant bacteria expected to exceed cancer-related death if this AMR threat is not well contained. For our part, a thorough clinical assessment is crucial for us to justify to use antibiotic for treatment of patient. We need to ascertain the underlying disease process, and if it is an infection, this assessment should enable us to predict what is the most likely pathogen associated with this kind of infection, and it should enable us to guide appropriate selection of antibiotic that will target the likely organism. And on top of a proper clinical assessment, our decision should also be supported by relevant lab investigation, of course, in order to establish a definitive microbe diagnosis and to determine the susceptibility of the organism to the various antibiotics by susceptibility testing. So assessment, not only in surgery, in other fields of medicine also, these are the three main indications for the use of antibiotic as therapy. The first one is for prophylaxis, where you administer antibiotic where the infection is still not there and you wanted to prevent the infection. The second indication is an empirical therapy, where the patient has already presented with signs and symptoms of infection, but you don't know yet what is the pathogen that caused the patient condition. And afterwards, after you review the culture and sensitivity result, then you can apply antibiotic for definitive or targeted therapy. So we will look into briefly all these three indications for treatment. So the first indication is for empirical therapy. I've listed here a few of the guides for you to decide on the empirical antibiotic therapy. You should have a clear indication, a strong suspicion of bacterial infection, and another important point to consider is that what is the likely organism and the pattern of local susceptibility profile. For example, you are currently working in a hospital where the prevalence of MRSA is high. So from there, you can in a way decide what kind of antibiotic that you wanted to use for your empirical therapy. And another things to consider is that the spectrum of antibiotic. By knowing the kind of infection, the most likely pathogen that caused that condition, you should somehow apply antibiotic or use antibiotic which have coverage against the most likely pathogen that caused the condition. So you should have this kind of knowledge also, the spectrum of antibiotic. And another technical issues to consider is that the pharmacodynamics and pharmacokinetics principle of the antibiotic. What is the amount of the dosing volume, the route of administration or the method administration, presence of any drug-drug interaction, and to consider also the side effects of the drugs. Okay, these are among the things that you should consider to guide your empirical therapy. And at the same time, you should also look at the patient. If the patient presented, if the patient that you are managing is currently a very young patient, presented with a very severe condition, you might want to hit hard on your empirical therapy. Okay. So I've outlined here the spectrum of antibiotic. We just take one for example. Okay, amoxicillin, clavulanate, augmentin. Augmentin and unisin, for example, these two antibiotics is considered as a broad spectrum because it can cover gram-positive, gram-negative, and anaerobes. So conventionally, as an option for empirical, you might want to use a broad spectrum first because you don't know exactly what are the most likely pathogen that what is the exact pathogen that caused the current condition. So these are the usual broad spectrum that you wanted to use lah. But if you were to compare, for example, cefepime to augmentin, the spectrum is broad, but the level of effectiveness of coverage is more focused for gram-negative bacilli. So in a clinical practice, for example, ceftazidime, cefepime is most likely used for a targeted therapy rather than an empirical therapy. But in selected cases, you might use ceftazidime or cefepime as an empirical therapy also. Okay, you can study this table later. So the next things to consider is that for antibiotic therapy is that what is the optimal duration of antibiotic therapy? Okay, currently there are few surgical infection for which the duration of treatment have been precisely defined. I will give you an example later. And since there is only a few kind of infection, so this reflects that the endpoint for assessing an antibiotic treatment is largely clinical rather than microbiological. Clinical means that you have to look into the patient clinical response and all those septic parameters for you to assess how long you wanted to give the patient the antibiotic. Rather than you should conduct repeat sampling to look at the microbiological response. So it doesn't work that way. Prioritization should be given to a clinical response rather than microbiological response. So, important things to highlight here is that a long-term empirical therapy with broad-spectrum antibiotic is really not recommended because of the previous reason that I've mentioned. It will lead to generation of antimicrobial resistance, and the patient might end up with hospital-acquired infection due to this MDRO organism, and it will cause them more trouble. And you also have trouble in treating them later on. And with regards to the optimal duration of therapy, there are increasing number of evidence-based trials that have compared effective duration of treatment for us to fall back on. So this is the example publication in the New England Journal of Medicine with regards to the trial of short-course antibiotic for intra-abdominal infection. The outcomes include the development of surgical site infection, recurrent intra-abdominal infection, or death within 30 days, and the secondary outcome include the duration of therapy and rate of subsequent infection. And the conclusion from this study is that in immunocompetent patients with mild to moderate peritonitis, with appropriate source control being conducted, 4 days of therapy was non-inferior in terms of the outcome to a mean of 8 days of therapy. So we are going for a shorter course rather than a prolonged course. All right. So another component is that de-escalation of antibiotic therapy. When I say de-escalation is referring to the initial short-term broad-spectrum antibiotic therapy, which is followed by changes to a more narrow focus regimen. Initially, you give a broad spectrum and you de-escalate to a narrow focus regimen based on the lab result and the clinical response of the patient. De-escalation of antibiotic therapy is important because it balances the mortality and the morbidity of a serious infection by limiting the potential adverse effect of long-term broad spectrum and primarily to prevent the emergence of resistant of organism or new infection such as the nosocomial infection. And however, we wanted to say that the broad spectrum initial therapy with a broad spectrum antibiotic, when it is given in the short term, it will limit the risk of emergence of antibiotic resistance, but not for long-term use. Broad spectrum antibiotic ini try to avoid as possible. Try to avoid using a broad spectrum therapy for a long-term therapy. And the choice of antibiotic regimen at all times should be based on the local microbiological surveillance data. The ideal thing is that for your institution to have your own local antibiotic guideline. That is the best. But this is the second best thing. If you don't have your hospital antimicrobial therapy guideline, you can use this, the National Antimicrobial Guideline, which is published by KKM in 2019. It is the latest edition. In this guideline, it specifies the indication of the antibiotic therapy, and the description is based on the specific type of infection. And the guideline also listed what is the likely pathogen that caused that specific infection. And it suggests what are the primary or the preferred and also alternative selection for empirical therapy. And it is completed with dosing, volume, and frequency also. And some of the infection also mention the optimal duration of treatment. So please make full use of this if you don't have your local hospital punya antibiotic guideline. Alright. So I will proceed. The subsequent few slides are basically the content of the guidelines. I don't think I will go into detail each and every one of the infection, but I think you can look through afterwards. I've listed a few. Okay. Mostly the listed here are all the surgical problems lah. But I don't think I've put any pages or tables for head and neck infection, ORL infection. I've not listed here. So you can get a copy of this guideline. It is freely available in the internet for you to review. All right. Okay, it is very useful. For example, Fournier's gangrene. It listed here what are the common organisms that can cause Fournier's gangrene and what is the preferred empirical treatment, which is, for example, tazocine or ceftriaxone plus metronidazole. As an alternative, you can also give unicin, and there's also comment afterwards. All right. Okay, this is the list of empirical antibiotics. Okay, next important indication for antibiotic therapy is for chemoprophylaxis. The aim of a surgical chemoprophylaxis is basically to prevent surgical site infection, because by administration of antibiotic as a prophylaxis, it reduces the burden of microorganism at the surgical site during the operation. So a single dose prophylaxis is usually sufficient, and the optimal time. If antimicrobial prophylaxis is continued post-operatively, the duration for a single dose prophylaxis should be less than 24 hours. The duration of antibiotic as prophylaxis should be administered to patient in less than 24 hours. Should not be more than 24 hours unless you think there is an infection somewhere going on. However, for patient with a pre-existing infection, and you can use the appropriate treatment regimen based on infection's condition of the patient instead of prophylactic regimen. But you may require a redosing prior to skin incision, right? So the optimal time for the surgical chemoprophylaxis administration is ideally 60 minutes prior to incision. However, few antibiotics may need to be administered earlier, for example, fluoroquinolone and vancomycin, because it need to be over slow infusion and it cannot deliver rapidly. And an additional dose of prophylactic antibiotic during operation is indicated if there is presence of excessive loss of blood more than 1.5 liter, or for procedure exceeding 2 half-lives of the drug, or if there are other factors that may shorten the half-life of the prophylactic antibiotic, such as in condition where there is an extensive burns. All right. I've listed here also a few pages of the options for antibiotic for chemoprophylaxis, for surgical chemoprophylaxis. Common surgical chemoprophylaxis is basically cefazolin in view of only single dosing and easy administered. All right. I've also listed a few also here, so you can look through afterwards. All right. Okay. So the next indication of antibiotic therapy in surgery is basically the definitive therapy. So a definitive antibiotic therapy should be at best guided by culture and sensitivity results. So in order to get an accurate CNS result, a good quality results, a proper specimen collection and handling is a very critical component in diagnostic microbiology. And specimen, as you all know, rubbish in, rubbish out. So specimen collection should be conducted by a trained and competent staff by using the correct technique. It should be taken ideally before antibiotic being administered, and it should be conducted following selection of the best suitable specimen for the suspected site of infection. If any of you are not clear, you can give a call to your microbe lab or call to your clinical microbiologist to ask for this. If you are not clear, what are the best type of specimen for you to diagnose that type of infection? And during sampling procedure, you should strictly adhere to all the universal precautions for collecting and handling of all specimens. And it should be conducted, and the technique of specimen collection should be conducted in a way to avoid contamination with indigenous flora. I give you one example afterwards for you to have a clear picture. And use the correct material for sampling and a correct container for transport. And ideally, for bacterial culture and sensitivity, the specimen should be transported to the lab without delay inside a proper packaging condition. All right, this is the example that I was talking about. Example of sampling from wound or abscess. I think this is common for surgical condition. So a lab basically requires a specimen, not a swab of a specimen. Okay, so we prefer actual tissue, aspirates, or fluids over swab. Okay, and if you can avoid taking swab, then it is better, because the swab itself is just only have a limited surface area where you can only take a limited amount of specimen, which the volume of the specimen directly proportionate to the yield of the culture and sensitivity. And at the same time, if you happen to swab, you most likely to swab the superficial part of the lesion, where at the superficial part of the lesion, most likely you will have a colonizer over there and contaminant over there. So we don't want to perform a culture and sensitivity result onto a colonizer and contaminant, because if you report you the result, most likely you will give the patient antibiotics based on that erroneous result. So we don't want that. Okay, so try to avoid taking swab and give us through tissue or aspirates or fluids. And if swab is unavoidable, that's the only thing that you can give us. You can do it by perform a simple cleaning first on the surface of the lesion and try to get a swab from the deeper structure, not the superficial structure. And if you were to happen to perform percutaneous aspirate or abscess or collection and taking a biopsy for culture and sensitivity, a strict aseptic technique should be applied. And rather than a bedside specimen, we would prefer more an intraoperative specimen. Okay, I hope you can get what the message that I'm trying to deliver here. Okay. So help us to help you. All right. So
Dr.
another,
Sorry.
yeah,
Shazah here. I've got a question on intraoperative specimen for CNS.
yes, Saja.
So sometimes you've got the pus, and then you've got you have the tissue available as well. So sometimes people would just send the tissue because they say tissue is the most will really guide your management, and then they won't send the pus. Or how would you
You
suggest?
can, you can send pus. You
Okay, send
aspirate
both.
the pus and put it inside a sterile container.
So send both basically, so it
Yes,
doesn't.
you can.
Okay,
Yes.
and then in terms of tissue sampling, so sometimes we've got a lot of slough, and then sometimes we don't actually know what part to send, so we just send all. So
Okay. Okay. For tissue selection, I think rather than sending us a slough or dead tissue, you might want to send a viable tissue, because in a dead tissue, most likely the bacteria there is also not viable. The process of inflammation or infection usually occur at the viable tissue. If you happen to localize a lesion, rather than take a central specimen from the center of the lesion, you took the specimen at the edge of the lesion, where there is higher chance for you to get a through pathogen rather than a contamination or colonizer.
all right, thank you, Doctor.
Okay. All right. So I think I've also wanted to highlight with regards to antimicrobial stewardship program. This is basically a program. I think virtually every hospital in Malaysia, I think established hospital should have this program inside their facility, including us in SASMAC. So antimicrobial stewardship program aim to prevent the emergence of antibiotic resistance. It is basically a multidisciplinary approach which involves a timely and optimal selection, dosing, and duration of antibiotics for the best clinical outcome of the patient to prevent toxicity and minimal impact on resistance. On the right side of the slides, I've put here the usual flow of an AMS team activity. Basically, we get the input from the primary team first with regards to what kind of antibiotic being prescribed, okay, or the input may also came from pharmacies, and the one in the lab, the clinical microbiologist or the scientific officer will analyze the culture sensitivity result of the patient, and afterwards we will get back to the where to look at whether the antibiotic being prescribed by the primary team is appropriate for that kind of culture results. So this is the activity. So all of this activity up to review. Afterwards, the team will plan for intervention, and it will be communicated with primary team. And we hope that surgical team, for example, can cooperate with the AMS team also in order to optimize the therapy for antibiotic therapy for the patient. It is also for the greater good to prevent the AMR. Okay, antibiotic stewardship program. You can also have a champion in the unit also to look into this matter, antibiotic stewardship. All right. So I've listed here one of the key measures for antimicrobial stewardship, which is the IV to oral switch. Okay, basically parenteral to oral switch. The benefits, I think you all know, includes a cost saving. Parenteral drug is relatively expensive as compared to oral, and it will eliminate the needs of ancillary supplies. It will reduce pharmacy time. It will reduce nursing time. It will shorten the length of hospital stay and increase the possibility of earlier discharge. It will eliminate the adverse event associated with parenteral therapy, and it will increase patient comfortability and mobility. Try in a way, try to find an opportunity to convert a parenteral to oral switch whenever possible. And the optimal time to consider for switching is between 48 to 96 hours of IV therapy, because at 48 hours basically you have an ample time lah, to evaluate whether either the clinical response of the patient to the therapy, or the microbiological results of culture and sensitivity. That one it will give you ample time for you to evaluate whether to continue with IV therapy or for you to switch to oral therapy. But it has certain strict criteria to conduct this switching procedure. And there are increasing numbers of reports of clinical trial that supports this early switching, which does not affect the treatment efficacy and giving not associated with any adverse effects on the patient outcome. And ideally, any parenteral antibiotic that is prescribed to patient or administered to patient should be reviewed daily after 48 hours. You should regularly review the indication. Please don't let antibiotic therapy goes weeks and weeks without being reviewed. Okay, we have unless we do acknowledge that there are certain types of infection that requires even up to 6 weeks of treatment. If the indication is clear, there's no problem. Okay. And before switching, the patient must meet a number of criteria, which the patient should display signs of clinical improvement. He or she should be able to tolerate oral therapy, and he or she does not suffer from condition where a higher concentration of antibiotic are required in the tissue, or prolonged course of IV therapy is essential. For example, you should not prescribe an oral therapy to a patient who have a GI issues, for example. Okay. So the details of the criteria can be reviewed. These are I've also taken from the National Antibiotic Guideline. All right. A few listed surgical condition is there. You can find ways to switching from parenteral to oral whenever possible. Okay, so I've listed here. Subsequent two slides are basically options of antibiotic for you to use. For which one is available. It also depends on the availability of the oral agent that you wanted to switch to. Plus, ideally, you should have the sensitivity results of the oral agent that you wanted to convert to. Okay. All right. Okay, so in conclusion, all of us should be clear with the indication of us starting antibiotic therapy. So at best, please customize your antibiotic selection based on your local data as much as possible. And you should also customize the course of treatment based on the patient's response and by referring to the locally established guideline. Okay, it can be as certain as a case-to-case basis. And the next point is that provision of a good quality specimen is mandatory for diagnostic, so that a meaningful result can be produced to guide your antibiotic therapy. And please give your full support to fight against emergency transmission of AMR. So I think for the first part of my presentation is already completed. Any other question, or should we? I can attend the question now. If any of you have anybody question to ask. Okay, no question. I hope you all clear lah. And the content of the lecture just now is meaningful to all of you and you can use in your practice later on. All right. So I will proceed with the second part of the discussion, basically the role of surgeon during COVID-19 pandemic. Okay. All right. So as an introduction, as all of you know, COVID-19 is basically a general issue across all medical disciplines, not only surgery. And for surgery in particular, it has significantly affected surgical practice in multiple ways. And surgical units should always remain prepared, like other units also, to meet the demands for patients hospitalized with COVID-19 and for patients in need for essential surgical services. Okay, I've listed here a few of the international guidelines as a guide for surgeons on how to approach COVID-19 pandemic and running their services at the same time. Okay, you can look through afterwards. But what is the common things among these guidelines is that it did mention with regards to rationing of services. It is basically a surgeon's role together with the hospital administration or administrator to analyze the risks and benefits of any planned procedure. And it is not only to evaluate the clinical situation, but you should also consider the conservation of resources that should be there to manage the COVID-19 cases. The local incidents, the rate or the burden of COVID-19 in your area, the supply of personal protective equipment, staffing availability, bed availability, especially the ICU beds, the ventilators availability, COVID-19 testing capacity of your facility, the risk of patient to acquire COVID-19 afterwards during immediate post-op recovery phase, and the urgency of the surgical procedure. These are among the factors that that should be considered for you to plan your services. So if the outcome of the evaluation is unfavorable, you may need to triage non-emergency procedure. So triage means you might want to minimize or postpone or cancel any scheduled procedures. And at the same time, surgeons should also participate in evaluating the situation to consider for reopening of service for elective cases when the situation is normalized. All right. The main guideline for Malaysia basically is Annex 22 guideline for management of COVID-19 in surgery, but it is last reviewed in 24th of March 2020. It's quite long time ago, last year, and it is yet to be reviewed. But the main obligation is for every medical personnel to conduct this screening upon you encountering a patient. Screening involves review of clinical symptoms of respiratory infection. You have to look at the epidemiological history, the exposure history, and as well as the travel history. And screening should be conducted at all possible entry points for each and every patient. And along the way, if you find any form of suspicion, you should confirm your suspicion by performing COVID-19 PCR. For COVID-19 case management, for each surgical unit, it is recommended to have your own management pathway based on your own logistic and resources available. And there should be a specialized core team standby to manage probable or confirmed surgical cases. And this core team should familiarize themselves with the infection control practices, and they need to ensure that they have the access to the right personal protective equipment. And ideally, this specialized core team should be optimally trained in donning and doffing of PPE, should be optimally trained with the specimen collection and handling for COVID-19 testing. And the staffing should be kept at minimum possible. And if the patient happen to require any forms of surgical intervention, and it should be done under a proper precaution where it involves a strict adherence to universal precaution, frequent hand hygiene, donning of proper PPE, doffing properly, appropriate clinical waste management, to ensure cleaning processes, disinfection processes is being conducted correctly, and another important point is that to consider a proper patient placement where ideally a negative pressure room or negative pressure OT is required, or if the resources is limited, you might end up by using isolation room, and the ventilation need to be proper. And any patient with probable or confirmed cases should be masked at all time, and minimum or movement should be minimized. And transfer, of course, you should have the hospital, the facility should have a designated route for transfer and transport of patient. And a dedicated OT is ideal, ideally should be available, which should be fully equipped, ideally a negative pressure OT where the location is easily accessible, ideally near an entry point, with a minimum staff to run the OT. Okay, for a patient with a COVID-19 infection who require any surgical intervention, if based on KKM guideline, the case should be deferred for at least 14 days. If he or she is due for elective surgery. However, there are publications from Indian Council of Medical Research which propose to delay any possible procedure for up to 6 weeks, because to ensure smooth healing and convalescence post-surgery. So I think it is up to you. The guideline is that uh, while we are waiting for a more definitive information on this, I think the guideline can help you to decide. All right. And it is generally not recommended to repeat a PCR if the patient presented at less than 102 days of diagnosis, because there's a big issue of false positivity due to capture of this non-viable virus particle. Okay, so try at your best to avoid repeating PCR within 102 days. Okay, and a COVID-19 reinfection can only be diagnosed after 102 days from the last positive test. Okay. Okay, I think that's all for the COVID-19. Any question?
Dr. Hidayah, I've got a question. So if, for example, a patient who has had a recent COVID positive infection within the 102 days, but when that patient presents to us, there are no symptoms. So so you can't repeat PCR. So technically you have to don a full PPE during the
Yes.
okay.
Yes. If you were to select 14 days, then within that 14 days, even patient have no symptoms, you're afraid that transmission might occur, then you should apply the appropriate protection. If you were to select 102 days, then within that duration of time, if the patient presented, although without manifestation of respiratory infection, the precaution is the same. All right.
I think we've got time for a couple more questions. Any questions from the floor?
Yes. Does the things that I've shared with you all is useful for your practice?
Yes, it's very relevant. Yes, thank you, Dr. Hidayah. I think because no one's got another, I've just got a question regarding RTK and PCR. So I think different hospitals have different policies, and I've been I was in Sabah when at the peak of COVID-19 just after the election. So what they've done is they've taken RTK and PCR prior to admission. And what we found was there were 3 to 4, while I was 3 months there were 3 to 4 cases where the RTK was negative, but the PCR was positive.
Yes.
So are we seeing any changes in our policy and guideline in this hospital due to the rising cases, or?
Okay. The decision whether to do what kind of testing, it is basically you need to, the decision should be based on the resources that available within that facility. If you are able to do more, then do more. If not, then we have to end up with which is the best option that is available for us to do. In which, in our situation, if we still does not prevent you from doing a PCR after doing an RTK antigen, if it happens that you have some sort of suspicion. I think that is the minimum thing that the KKM is suggested for us to do. But in a way also we do more basically, because in KKM hospital over in Semenanjung, basically they don't also you do RTK, but in the initial phase of the pandemic. But afterwards, some of the, I think maybe some of the KKM hospital also take this strategy of testing using RTK antigen or prior to admission. So the role of testing is there, but the limitation, there's no test is perfect. Even PCR is not perfect. PCR is a very ultra sensitive test that can pick up even the smallest contaminant, which may lead to false positivity. That's also possible. And RTK also have its limitation. So in order to cover up all of this limitation, I think at certain point, clinical assessment, clinical judgment, your assessment is also play a big part for you to decide whether which test you wanted to use for the patient. But as for Sasma is concerned, for every admission, screening is ideally still being conducted by using RTK antigen, but upon any suspicion or any inquiry, the suspicion or inquiry should be confirmed with PCR. Because if you were to do PCR for each and every admission, it is not cost effective. Not cost effective, and somehow it interrupted the management, the flow of management of the patient also. So we have to weigh between all of these pro and cons lah, for which test that you wanted to results to. Huh? Okay.
Right. All right. Thank you, doctor. And anyone else with any burning questions? No. All right. Okay. So I'd like to thank Dr. Hidayah again. The timely reminder about COVID and the pandemic and how it has affected us, and the reminder of our role in antimicrobial stewardship. Thank you for spending your Saturday with us. I hope you enjoy your long weekend. Thank you, doctor.
When you are having your exam?
So it has been postponed to
Okay, so you have ample time to study, alhamdulillah.
mid-July.
So I wish you all the best, inshallah.
Right.
So hopefully all of you come out to be a very good surgeon, inshallah.
All right. Thank you. Assalamualaikum.
Waalaikumsalam.